Hello and welcome to the 12-lead lecture for the Intern BootCamp. This lecture is going to consist of how to systematically read a 12-lead, how to interpret 12 leads, and hopefully how you can fix those rhythms as you come across them. Alright, so this is the overview of a 12-lead. I'm sure you've all seen them. And the really important note on this slide is always compare from prior 12 leads. And in Epic, you'll be able to do that under the chart review tab under cardiac procedures. And there's a little button that says EKG. So why do we compare? Well, obviously, if there's any acute changes, if we have resolution of any type of abnormalities, which we'll go into a little bit more in depth in this lecture later on. But more importantly, you need to know how to find a STEMI. And the STEMI is built on what leads you look and where they're at. So for example, your inferior leads are 2, 3 AVF, your lateral leads are 1, AVL, V5, and V6, and then your septal anterior leads are V1 through V4. Now the one that is left out is AVR. This is a special case scenario, and this is kind of a trick question that you may see on your exams. But if you have ST elevation only in AVR with ST depression kind of universally throughout the rest of the leads, that's usually going to be a proximal LCA or RCA infarct or obstruction. So this is just a picture of what we're talking about in terms of the leads we just discussed as well as their location. So you see that 1 AVL, V5, and V6 are the circumflex branch, and that's usually going to be on the left side. The 2, 3 AVF are the right coronary artery, and then V1 through V4 is going to be the left anterior descending, with V1 and V2 being the proximal aspect or the septal aspect of it. So proper lead placement is very important. Obviously, if you don't have the right leads on the right areas, then you're not going to get the right readings. Whenever you look at a 12 lead, it's based on electrical potentials, and so therefore the electrical potential is going to be important, because if the placement is incorrect, then it may have a reversed polarity, thereby representing an inverted T wave or an abnormal QRS complex and whatnot. So on the right here, we have the 4 lead placement. You have your right arm, right leg, left leg. And usually you'll see them put it onto the trunk, and that is perfectly okay. The alternative is putting them on the distal aspects of the extremities, which is also okay. Some schools of thought will say this is actually more effective because it's getting you the furthest potential. In the hospital, very rarely will they ever put a 4 lead on the arms and the legs. They'll literally just put them on the chest and the abdomen. Now, the 12 lead placement on the left side of the chest versus the right side of the chest, most of the time it's on the left side. There's only certain circumstances when you're thinking that you have a you need a right-sided chest 12 lead is for when you have inferior wall / posterior wall infarct, and then the left side is mainly the predominant area you're going to put them on. So it's always the fourth intercostal space, left and right peristernal, and these are the ones that you start with, and then from there you skip one, and then you do right underneath the mid-mammillary line, which is going to be V4, then you skip one again, and the anterior mid-axillary line is going to be your V6. From there you can literally just put it into the holes, into the gaps. So you start at fourth intercostal space, right and left peristernal, with V1 being on the right and V2 being on the, V1 being on the left and V2 being on the right, and then you skip mid-mammillary, skip mid-axillary, and then you fill in the gaps. So that's V1, 2, 3, 4, 5, 6, and then on the limb leads, you literally just put them on the appropriate limb, and then you'll notice right here V4R. V4R will give you that posterior view, and then you literally just take V4 and move it over to the mid-mammillary line on the left side. So let's talk about how to interpret rates. So starting from the left over here, we see this is one big box. One big box is considered to be 5 millimeters, and then you have little boxes or 5 little boxes within the one big box. So the standard rate of speed is 25 millimeters per second, and that is a standardization in America. Each one of these little boxes equals 0.04 seconds or 40 milliseconds. Each one big box represents 0.2 seconds or 200 milliseconds. So if you're going to use a convention, you have to stick with it. So if you go by milliseconds, stick with milliseconds and vice versa. I personally use the 0.04 seconds because that's what I learned whenever I was in school. This can be used to calculate close rates, meaning the PR interval, the PRI, or the QRS interval, the QRSI, or the Q to T interval. Those are all going to be utilized with the little box and the big box. If you're looking at just standard rate, if you go down here, you can start at a point where, say for example, looking over here, this QRS complex starts right on the start of one big box interval. Using that as a starting point, you hop over to the next until you get to a QRS complex. So let's just say, for example, the point of a QRS complex is at this starting point. You hop over, it's still not there, hop over, still not there, hop over. It's right around here, so you know it's about 100 beats per minute. Using that logic, let's start with a sinus tachycardia, or excuse me, normal sinus rhythm right here. And we can say it's roughly about the same size. It's just two little boxes, so we'll calculate. So 1, 2, 3, 4. So we have 4, so that's 1, 2, 3, 4. So it's roughly around 75. Using it on this bradycardia, 1, 2, 3, 4, 5, 6. So that's 1, 2, 3, 4, 5, 6. It's roughly around 50, which is less than 60 beats per minute for bradycardia. Tachycardia is anything up to 140, 150. Usually signs of, fever, pain, things like that. If you're above 140, 150 consistently, then you need to start worrying that this may be something else. Sinus tachycardia does not usually go that high. Using this line of logic, we have 1, 2, so it's roughly about 150. So the bump method, which is the hot method right here, is a very useful tool. Now obviously these secondary numbers are very good to know about, but usually if you know you're in a range of 300 to 150, then we're in SVT range. 150 to 100, we're in the tachycardia range, and then 100 to 60, we're in the normal sinus range, and then 60 and below, we're in the sinus bradycardia range. So breaking it up into parts and knowing that, man, if I only jump once, we have a problem. Those are really important to help you diagnose and treat things. So going to the bradycardia rhythm right here, you can see that we have a P in front of every QRX. Our QRS interval is tight, meaning that it's less than 120 milliseconds. Our PR interval, backing up a point, is less than 200 milliseconds. You can start from the start of the P, so that's 4, 8, 12, 16, 20, it's right there. And then we have our T waves being upright. We do not have ST elevation, although you may see that it looks like it's roughly just above the bioelectric line, which is the standard line right here. It's not even a millimeter. It's not enough to write home about. So using what I just did, see if you can't do that for the next two lines here. We talked about P, QRS, we talked about the intervals of both, the T wave, and then we also talked about ST elevation. That's just part of the whole solution whenever you're supposed to interpret a 12 lead comprehensively. But going down to our normal sinus rhythm, why don't you try to do that right now? I'll give you a couple seconds. Okay, so if you paused it, that's fine. If you haven't, that's cool too. So we're looking over here at the PQRS and the T wave right here. We've already calculated our rate previously. We said it's 1, 2, 3, 4. So it's roughly 1, 2, 3, 4 between 100 to 75. It's well within normal sinus rhythm. You look at the P wave, you see that it starts right here and it's roughly 4, 8, 12, 16.16 seconds. The QRS is tight, it's less than 0.12 obviously. Then you look at the ST changes, there are none. The ST segment is at the bioelectric line. T waves are upright, there's no additional waves, and that is a normal sinus rhythm day in, day out. Sinus tachycardia, same thing. We have already mentioned that it's between 150 and 100. And you can see a P wave. That's another important point. SVT and AFib, A-flutter lose their P waves. So you do not, you have your P wave, you have your QRS. Now, one may be concerned that you have this like ST depression looking thing because the bioelectric line is right here. And I'll just highlight that real quick. Here's your bioelectric line, and you see that your T wave is down, or your ST segment is down there. That is completely normal in a tachycardia. Tachycardia does some crazy things. It makes things go up and down and elevated and depressed and whatnot. But that's just because the heart's working really fast and it's doing a lot of things. So to say that, oh, I have a STEMI, we need to get it down before we start making assumptions based on our rate and on tachycardia. So let's talk about regular versus irregular rhythm. So one of the components that you now need to add into your algorithm there is when you feel that the rate is, high, regular, or low, then you also need to assign, is it regular or irregularly irregular. So looking at our rhythm right here, we have our regular rhythm, and you can show that this is the same slide from the previous one with normal sinus rhythm. You'll see that there's 0.08 seconds from the start of the big box, roughly. And so you go over here, 0.08 seconds, 0.08 seconds, 0.08 seconds, and you know that it's a regular rhythm. Now sometimes they're not as obvious as this, where you have like a bunched up QRS complex next to the other one. Instead, it'll be, regular and then maybe a little irregular and regular, and that's when they say to bust out the calipers. I don't carry a pair of calipers with me, so you may just have to continue to try and evaluate that rhythm with your eyes, and you can also, on the PDF version of the 12-lead printout that you get on Epic, you can actually use a ruler function and see if it's the same distance in between. That's your calipers. 21st century stuff. So on this right here, you see the irregularity of it. You start at the 0.04 and then you end well early above the 0.04. Then you go a little bit farther, but you notice you have two boxes in between. This is obviously an irregular rhythm, and knowing that our two or three irregular rhythms are AFib, AFib RVR, and a flutter as well. So here we have what we were just talking about, AFib and A-flutter. You see right here that you have this abnormal beat in the middle of the segment here, and it looks like everything else is pretty much normal. Well, one needs to make sure that this is not a PAC or a PVC, and knowing that our ectopic beats, like premature atrial complexes, will lose their atrial beat, which is their P wave, and PVC will have a full atrial beat with a P wave, as well as the QRS complex is usually wide and abnormal compared to the other ones because it's an ectopic ventricular beat. These do not have P waves, but if you look in context, there is no P wave in front of the other complexes. Therefore, you will not have a atrial flutter, atrial fib, that's going to have P waves on these complexes. Now, there are a phenomenon in which you can have a flutter or a fib as the presiding rhythm, but then you have a PAC or PVC, and it gets kind of confusing there. You remember, when in doubt, always ask. Go and ask somebody and have them interpret it with you until you feel more comfortable with the rhythms. So now this right here, you can see that you have fibrillatory waves. This is AFib, and you can see that we have this irregular rhythm right here in the middle. Go into the A-flutter section, you see we have sawtooth waves. You look like if you put your hand on it, that thing can cut into a log. And that's really what that sawtooth pattern comes from, is that it looks like a saw blade. And this is a 2-to-1 pattern here. And this jagged, rough rhythm right here is going to be your predominant distinction between AFib to A-flutter. Now, one could say, well, it looks pretty regular. It does look kind of regular, but then you have these little irregularities where we lose some, gain some boxes, we change some. So you have to be, aware of your context clues here. All right, so we talked about the rhythm and the regularity of a rhythm. Now it's time to go into the P wave itself. You always have to look at the P waves and the rhythm strip, as well as evaluating P waves in the other leads as well when you have a 12 lead. And the reason for this is because a normal P wave is upright. It's not bimodal like this, or two little humps, okay, which can mean left atrial enlargement or right atrial enlargement. It's also going to be present in front of every QRS complex. Now, you can quickly ascertain whether or not something is going on if there's an absence of P waves or they appear fibrillatory, and that would assist you in the diagnosis of AFib, A-flutter, and other abnormalities that can be seen on a 12 lead when it comes to atrial pathology. So the PR interval, the most important thing on this slide is how long is it? It's 120 to 200 milliseconds, or 0.12 to 0.20 seconds. This is important because if you are above 200 milliseconds, then you are now in the AV block range for our first, second degree type 1, type 2, and third degree blocks. So continuing from the previous slide, you know that 0.12 or 0.20 milliseconds are 120 to 200 milliseconds. If you have a first degree, it's greater than that, meaning that you have an extended, prolonged PR interval from the QRS complex with no drop beats. If it's a stable and they're okay, this is common in elderly and people who are taking AV blocking medications like calcium channel blockers and beta blockers. This is nothing that you need to worry about unless they're symptomatic. And what is symptomatic? Short of breath and organ compromise, things like that. Going to the second degree type 1, you start to move into the treatment phase area here. And the second degree type 1 is a prolonged PR interval. It gets more and more prolonged until eventually it drops a whole beat. Now that whole beat is a non-perfusing rhythm right there. And this can be a problem, especially if someone is dependent upon that beat because they have low reserves to begin with. So that drop beat is a type 1. Now the type 2 is you have a prolonged beat, and then it's just a random drop, and it just continues to go on. And this can be very serious because right here you are already at a bradycardic rhythm, and now all of a sudden we have a pause for greater than a second. And that's a problem for intracranial perfusion and coronary perfusion pressures as well. So you'll notice that the third degree block that we're all familiar with, and I'm sorry for this drawing red, the P to P interval is different than the Q to QR interval. And this is important because these are asynchronous steady beats, meaning that they are doing what they're going to do no matter what the other is doing. And a third degree block is an almost complete block of the AV bundle itself, which means that you are literally perfusing at the Purkinje autonomic pacer, which is less than 40 beats per minute. And you can see that right here, the ventricles are beating at less than 60, which is what our threshold is for normal beats. So anytime a patient is unstable with a first or second degree type 1, you're going to pace them, and you can give atropine. If they're unstable or stable with a type 2 or a third degree, then you're going to need to pace them. The reason for that is because atropine doesn't really work anymore in the type 2. You could still give it, but it's not really going to work very well. And then third degree, it won't work at all. So the ultimate treatment for these conditions is going to be a pacemaker. So let's talk about QRS complex. So we talked about the P wave being upright and the PR interval. Now it's time to talk about the QRS. The first thing you ask is, how long is the QRS? And do you have any type of abnormal variations of the QRS? And then finally, is the QRS regular compared to its others that are in the strip? So the QRS interval should be less than 0.12 seconds or 120 milliseconds. If it's greater than that, that's a problem. That's considered to be wide. Regular means that is it the same from each QRS complex. And this is important because irregular Q waves that are wide, well, what does that mean? That means you better shock them because that's probably VFib. And then regular Q waves that are wide, that's VTAC. And you should probably give them a medication if they're stable enough, or shock them. So let's look over here at our QRS. We've already talked about the duration. It's going to be 0.12 seconds. And then you look over here, we have our normal P waves. You have your QRS, and then you have some others. More importantly, the bundle branches. So our right bundle branch and our left bundle branch, okay? So the way I learned about the right and left bundle branches is because if you look at V1, all right, V1 is what you're going to see for your right bundle branch. If you remind yourself about what it's like to drive a car, if you click down on the blinker or the signaler, you can click down, and that's where the S is going to be at, and you're going to see RR, and it's going to look like these little W here, and that's what you would normally see for a right bundle branch on V1. Now on the alternate side for V6, if you click up on the signaler, then that's going to make it left, and that's going to be your left bundle branch. So these are very important things because we also use these to make a diagnosis of a STEMI after a STEMI, or even a STEMI within a STEMI without any type of ST changes. So if you do not have a previous 12 lead that shows that they've had a right bundle branch or a left bundle branch, and now they're coming in with typical anginal pain, and you see that, oh man, they have this alternate change in their 12 lead, then that would probably indicate that there is going to be a change, and at the very least they need to be evaluated by the cardiologist and the patient. At the very worst, it could indicate that they could be having a new onset STEMI. So that's the QRS complex, and bringing it over here, remember, P waves upright, how long are they to the PR interval, and then you go into the QRS, is it wide or narrow, is it regular or irregular, and those are the two questions that you ask. So moving on to your T waves, so really the one that we need to worry about is going to be upright or inverted, okay? And you see here we have a normal T wave, normal variance, and then within the upright and inverted, do we have really upright T waves, which would be the hyperkalemia, and the way I learned about it is it's called the witch's hat. It would hurt to sit on it. These are usually going to be Ks greater than 5.5. And then in our fluids lecture, we have further elaboration on potassium and how that affects the T wave morphology. And then we also have hyperacute T waves, and you'll see here, here's the J point, and then here's where you have the ST elevation. This would be seen in ischemia as well. Other thing that we need to talk about is inversion. So the typical progression of an ST elevation myocardial infarction can cause your T wave to become, here's normal, become flat, become inverted, and then become ST elevation. And that's usually the progression of it. So if you see inverted T waves, that's the reason why you're looking at it to say, man, that's not normal, that they should be upright. Oh, that's a change from the 12 lead they had a couple months ago. This is something I need to look into. One more thing that I wanted to bring into the picture here is a cerebrovascular insult. Whenever you have a gigantic T wave, this does not do it justice. We're talking about the things that look like this on the 12 lead. They're really deep T waves, okay, and that's supposed to be the QRS, I apologize. But those are called cerebral T waves, and that is a very strong possibility that you have a subarachnoid hemorrhage or an intercerebral hemorrhage. So if you see very, very deep T waves, then you know that there's something to be aware of. So the ST elevation is the one that everyone gets excited about. ST elevation means that here's the isoelectric line and here is the J point. It's up. So you know when you see this, this is a problem. And if any time that you see a ST elevation in congruent leads, 2-3 AVF, 1 AVL, V5, V6, or V1 through V6, or even if you have a very elevated ST segment in AVR and everything else is PR depression or ST depression in the rest of the leads, that's something that you need to be really concerned about. That should be emergency department if you're in the clinic, or if you're already in the emergency department, it's time to run the STEMI alert and get talking with your attendings and whatnot to make sure that you are not missing a life-threatening event. So the last thing we didn't talk about, but save the best for last, is the axis. I use the 2 thumbs up model. So what I want each of you to do is put both of your hands in front of you with your thumbs up, okay? So what you do is you look at lead 1 and then you look at AVF, okay? So if lead 1, the predominant QRS complex is upright, and the predominant complex in AVF is upright, then you have a normal cardiac access. Now, if in lead 1, the predominant QRS complex is down, but the AVF is up, then you're going to act like you're hitchhiking, you're going to go to the right. And that's the right axis deviation that we're talking about right here. If the lead 1 is up, and AVF is down, you're going to hitchhike to the left, and that's left axis deviation. What does that mean? Well, looking over here, if you have a left axis deviation, then it just means that the heart has moved over more towards the left side, indicating that you may have left ventricular hypertrophy, or you might have enlargement of the left atrium and the left ventricle, who knows. But it's just another piece of the puzzle to include so that you are understanding the pathophysiology of the patient's presentation. So, dangerous rhythms, things you have to act on immediately: SVT, AFib with RVR, Wolff-Parkinson-White. So, with SVT, you'll notice that it's greater than 150 here. In SVT, you're going to use vagal maneuvers. You're going to tell them to bear down, tell them to blow into a syringe. You're going to tell them to, some people have tried to tell them to whistle and whatnot. Those work maybe about 15 to 20% of the time. And you're going to have reoccurrence, so you have to try it again, and then maybe it'll resolve itself. Then you use adenosine. And adenosine is used when you know this rhythm is an SVT. So the standard protocol for adenosine is 6 milligrams fast push. That means within seconds with a flush, and then you do 12 milligrams and 12 milligrams. So in some literature now, there's pushing for you start with 12 automatically because 6 never works, and then 18, 18, and then you go to the next level would be 24 milligrams of adenosine. That has not been pushed out by the ACLS or the AHA, but you'll notice that some of your colleagues will say, hey, let's just try to 12. Sometimes, and I have seen it anecdotally, that 6 milligrams will work on a patient with SVT. And what kind of patients are you seeing with SVT? You're seeing young patients, you're seeing people who are off of their medications and they're on several rate control medications as well. And you can also use adenosine when the rhythm is just so fast that you cannot determine if it's AFib or RVR, because it could literally be very like 200, 250 beats per minute, and you do not see P waves. Obviously, it's going too fast for P waves. In addition to that, it looks pretty regular because the interval between each QRS complex is so tight. So you can use adenosine to slow it down to see if you have AFib. And if you have AFib, then you're going to switch over to a calcium channel blocker or a beta blocker in order to convert them. If the patient's unstable, the question on the test is going to want you to cardiovert them. You're not defibrillating them, you're cardioverting. There is a distinction, obviously knowing that cardioversion means you're syncing it to the QRS complex versus defib, I'm just shocking you. So you have to make sure that you are very aware of the language that's utilized, cardioversion for rhythms other than, rhythms that are VFib, you're going to cardioverт, or excuse me, defibrillate. Other ones you're going to cardiovert. So the reason you do that is because if you do land on the Q on T phenomenon, then what's going to happen is you're going to send them to VFib and they're going to die. So that's why it's always important to sync up your monitor so that you can shock on the right time. Now, I mentioned cardizem. Cardizem is a very important medication. It's a calcium channel blocker. Your cardizem is going to be mainly used as a refractory medication to SVT, that's refractory adenosine and vagal maneuvers, and as frontline for AFib with RVR. And AFib RVR is usually greater than 130 to 140 beats per minute, and they're having signs of an organ compromise, chest pain, shortness of breath, so on and so forth. So what do you do with that? Well, you're going to recognize the rhythm. This is an obviously irregular rhythm. You cannot appreciate P waves, and even if you do, they look somewhat fibrillatory. This patient's obviously in extremis. They're not doing very well. You start with cardizem first, unless they're unstable. Unstable means hypotensive, they're unconscious, things like that. And you're going to give them the cardizem dose. Now, the cardizem dose is supposed to be 0.25 mg per kg. Unfortunately, that would mean for our very large patients that you're going to give them 30 milligrams of cardizem. That could be a problem. Cardizem is not a benign drug. You will cause them to bottom out if you give them large doses of cardizem. So what you really need to do is, the old adage is you can't take it back. So if you give them 15 milligrams of cardizem, wait a couple minutes, see if they convert, and then if they didn't convert, give them the other 10, which would give you a max dose of 25, which is what it's supposed to be. Then they convert, no harm lost, you're okay. But giving a long, large bolus of 25 milligrams of cardizem is dangerous. So you want to make sure that you are able to differentiate between, unstable and stable, and how much medication you need to give at one time. You can give smaller doses. So again, cardioversion for an AFib RVR that's unstable. Now, remember, there are rules about the amount of time that you would cardiovert somebody and whatnot. If they've been in the AFib longer than 48 hours, if you cardiovert them, then you could shake the tree and the auricle will loosen its clot and send it to the lungs, and now you have a PE. Or if it's on the left side, it's going to shake it and cause you to have a stroke. Yes, that is for stable patients. If you have a stable patient that's been in AFib RVR less than 48 hours, you technically could cardiovert them. Most of the attendings will not. They'll send them to cardiology. If you have an unstable patient, then that rule does not apply. Unstable means life-threatening, means it doesn't matter if they've been in AFib RVR for 2 weeks versus 2 hours, you need to get them back. The final thing is Wolff-Parkinson-White. Wolff-Parkinson-White, you'll notice the delta waves right here. And you see right here, if you shock a Wolff-Parkinson-White that's unstable, or you give them cardizem, or you give them metoprolol, those are all AV nodal blockers. And the pathophysiology of Wolff-Parkinson-White is it's an ectopic alternative pathway. I'm drawing right here the AV nodal junction here, and this is where most of the pathway goes through, this AV node. Unfortunately, there is an ectopic pathway, somewhat akin to what we see when we have PACs or PVCs and whatnot. But the Wolff-Parkinson-White pathway originates from a different foci and then circumvents the AV node and then goes into the electrical conduction pathway after the AV pathway, and so therefore it will be able to generate its own rhythm. Well, what happens is if you block this AV pathway here and they have true, honest Wolff-Parkinson-White, you will then send them into a lethal rhythm. So the reason, and this is a good test question right here, if you see these delta waves, these really rough upstrokes, you're going to treat them with percanamide. And percanamide is the only treatment that you are to treat them with per the test question. Now, per Amamatu and several other cardiology specialists and emergency medicine, as well as medicine period, most of the time, if you would give them cardizem or metoprolol, you're not going to send them into a lethal rhythm, but the potential is much greater than, say, for example, AFib or SVT. So you always need to look, the question in your mind needs to be, do I see a delta wave? Do I see a delta wave? And if you do see a delta wave and they're experiencing, end organ compromise, shortness of breath, chest pain, things like that, then you need to order percanamide. The pharmacy does have it, by the way. And call cardiology, obviously. If they're unstable, always cardiovert. Always cardiovert for the test. In real life, they're like, how unstable are they? Can we get away with medicine? So making sure that you're having a earnest discussion with your attending. So VTach, VFib, torsades, and asystole, these are our standard rhythms right here. With our VTach, you'll see that's wide and regular. You can use amiodarone, 150 milligram drip over 10 minutes. That can be your first drop. If they're unstable, you're going to defibrillate or cardiovert. Some resources will say cardiovert all of them, regardless if they have a pulse or not. Others will say if they don't have a pulse, defibrillate them. Just use your best judgment. If you see a QRS complex that's kind of organized, then sync it up. It's always best to just sync. And then you would give an amiodarone. If they're unstable, you would still do the drip. If they go into an arrest, then it becomes the push per ACLS, and obviously CPR if they're unstable without a pulse, and epinephrine to keep them going. VFib right here, you'll see that we have it kind of looks like torsades, looping around here. And so this may be torsades, it may be VFib. You obviously want to look and make sure that you have a good kind of assessment of what's going on whenever you look at these leads, because this one's a lot more loopy than the other. So I apologize for that. So with your VFib right here, these are most of the time, 99.9% of the time, rhythms without a pulse that's palpable, and so therefore you're going to start CPR, you're going to defibrillate them, you're going to give them amiodarone, you're going to give them epinephrine, and so on and so forth. And the most effective way of getting someone back from these rhythms is early use of an AED and high quality CPR. Those are the two most common and important causes for return of spontaneous circulation, or ROSC. So torsades, you do everything that you were doing with VTAC VFib, but now we're adding magnesium sulfate at 4 grams IV push. If they're stable, which good luck, that's a miraculous patient, you're going to give mag first, then amiodarone, and you would still do 4 grams and then 150 milligrams. Asystole, same like ACLS, CPR, and epi. Now, remember, when you look at the progression of this, torsades is a special rhythm. But if you look at the progression of VTAC to VFib to asystole, you'll notice that the ventricles are starting to become more and more ectopic, and more of a physiological point here. This is all about ATP, or adenosine triphosphate. Whenever you have a normal rhythm, you have enough ATP to go around through the cardiac junctions, and those intercalated discs allow for the exchange of material and energy to go between. As you start to become more and more irregular and less physiologic, those intercalated discs are unable to successfully move the ATP around because they just don't have synchronicity of the mitochondrial production. And so with VTAC, you have a very good chance of getting them back with early intervention electrically and with compressions. VFib, we start to have a decrease of success, and then asystole, we have a very large decrease of success. And the reason for that is because it's just the energy. If you don't have any energy to go around, no matter how many times you shock or push on them, then you're not going to get anything moving. So with asystole, the most important thing is CPR, and with VFib and VTAC that's not witnessed, meaning that you don't just see them and they go down, then you need to do compressions in order to circulate around. And there's even the old mantra that even after you get them back, they have a palpable pulse, or if you shock them, rather. If you shock them and then you see a good rhythm on the monitor, you want to continue doing CPR for another round in order to give the heart the chance to circulate the medications that you've given and to circulate that good ATP around. So let's look at this inferior wall STEMI right here. So we know that 1, AVL, V5, and V6, I'll label them for you. These are our lateral leads, all right? And then we have V1, V2, V3, and then V4, and this says V4R on here. We can just remove that for the time being. So I chose the ones that don't have any type of changes, so or do they? So looking at our 12 lead for our ST elevations, I always start with lateral, anterior, and then I go to inferior. So this is going to be our inferior. Oh, we start to see some changes right here. I'll change the color for us so that we can see it. All right, and then AVF, we kind of have this like weird rhythm, but we see that we have abnormality in 2 and AVF, so that's 2 contiguous leads. And then we go over here, we look at our lateral leads. Oh, we have some ST depression right here, and then maybe a little bit here, maybe a little bit here, not very much. And then we go to our anterior leads. It looks like, man, we got some here and a little bit here. So this is what we would call a inferior wall MI with reciprocal changes, and the reciprocal changes are seen both in the lateral and the anterior leads. So understanding that it doesn't have to be a glaring STEMI, but if you see this ST elevation, that should really make your radar ping and say, this is something serious, I need to pay more attention to this. This is an anterior wall STEMI right here. So again, using our nomenclature, here's our lateral, 1, AVL, V5, V6. And then we have our inferior right here, our 2, 3, AVF. Oh, sorry, that's the rhythm strip. Delete that for a minute. And then we have our septal leads, our anterior, so V1, V2, V3, and V4. And Lordy, if you wouldn't see this, we have really big changes here in the anterior leads. We have some changes in the lateral leads. We have elevation right here, elevation right here, and we have a little bit of depression there. So this is what we would call an anterior lateral STEMI, which would be LAD to left circumflex. And so this is a big STEMI, y'all. This is definitely a STEMI alert that you would need to call the cath lab for. So let's talk about our lateral STEMI right here. We have our 1, AVL, V5, and V6, and man, I can already see it right there. Then we have our inferior leads, 2, 3, AVF, and then our anterior, V1, V2, V3, and V4. So man, we got another big STEMI right here, a big honker. So 1, AVL, V5, and V6. And then we have elevations in V2, V3, V4. So this is another anterolateral STEMI, LA to LCA. And then more importantly, we see here our reciprocal changes for our inferior leads, which would be a good indication that this is STEMI, this cath alert. So how do we treat it? All right, so if you have a good history and you review the 12 lead and it says, man, this is a good MI, you get the troponin, and then obviously the most important step that they miss right here is 12 lead. So if you have a 12 lead that shows you to have ST elevation like we saw before, that's automatic cath activation. This is going to be for our patients that don't have a positive 12 lead. You check the troponin. If they have a positive troponin, then you would need to initiate, cardiology consult and aspirin, Plavix. If they're having a type 1 non-invasive, now this is the cardiac cath stuff, and this is taken from a cardiology aspect here. But type 1 is they're having a true STEMI, aspirin, heparin, and then cardiac cath. If they're not having a true STEMI, meaning that they're having an NSTEMI, then you would do aspirin, and then you would use clopidogrel, and there are other medications that we currently use at the discretion of our cardiology department as well. Now a type 2 STEMI, which is just an NSTEMI without any concerns for like true STEMI, then you would use you would give them aspirin immediately, and then if they're having to use nitro for relief, you obviously go through that. These patients obviously need to go to the emergency department. This is not a we're going to treat you in the clinic kind of a thing. If there is no troponin, or if the troponin is elevated not due to an MI, again, this is not going to be a clinic discretion. This is going to be cardiology discretion, and you can have a myriad of things that can raise your troponin, illness, injury, and so on and so forth. So that would be after a workup that's done by the specialist. And this is the NSTEMI treatment pathway. This is what you normally see. In the ER, we use the HEART pathway, which stands for history, EKG changes, age, risk factors, and your troponin levels. There are many other types of diagnostic criteria that we can use aside from the heart score, but that's the one we predominantly use, and we'll talk about that in our cardiac labs. But if you have someone who has chest pain that is pressure-like, non-radiating, and it's not reproducible, then the that diamond criteria then can be used for a true anginal equivalent. And so if they have risk factors plus the probability based on their physical exam and history, then we need to work them up for anginal pain, and that's an ER visit. So if they're, let's start at the indeterminate risk, they don't have any high risk features, then ECG is okay in the clinic. You can maybe start them off on an aspirin and then observe them in the ER and observation wing. And then if they still don't have any high risk factors, then you can schedule out an outpatient stress test and whatnot. And so you don't need to worry about, well, I need to get them done right away. But anytime that you have someone come into the clinic with chest pain that's active, you do a 12-lead and send them to the emergency department. That is the protocol for the clinic. So if you have a high-risk patient, meaning that they have true, honest-to-God problems, cardiac troponins elevated, or they have a 12 lead, which we get a lot faster than a cardiac troponin in the clinic, then you send them immediately to the ER. You're going to give them aspirin, clopidogrel, and then give them on Lovenox to help them mitigate the further progression of their clot. And then from there, it's going to be cardiology's baby. They may just want to treat conservatively, or they may want to put them into the cardiac cath for revascularization. So NSTEMIs can either go really indeterminate and just watch for ACS protocol, or we need to get cardiology involved. And the most important part of this slide is knowing that whenever you have a patient that's being admitted for ACS protocol into the wards, then it's troponin every 6 hours, and then if they continue to go up, cards consult. If it goes down, all right, just follow up. And then they're going to need a transthoracic echocardiogram and a stress test. On Friday, Saturday, Sunday, that's very difficult to acquire. So this needs to be a shared decision-making conversation with the patient to make sure that you provide the best needs for the patient while not piping up the hospital, and of course, as always, talking to the attending. All right, well, that concludes the 12-lead lecture. I hope you learned some things. If you have any questions, just be sure to ask one of us, okay?